Over the next couple of lectures, we're going to talk about all the gynecological cancers. There's too much information to be contained in one lecture, but in this lecture, I'm going to give you an overview and set up the structure we're going to keep using time and time again. The first one of these, which is very important, is the idea of how cancer develops. Some etiology, some risk factor, predisposes the cells that get exposed to form a precancer. Precancer is dysplastic tissue that has yet to invade the basement membrane. If allowed to continue to exist long enough, that precancer turns into full-blown cancer. The time it takes for this to happen is variable depending on the cancer, and every cancer has its own precancer state, its own cancer state, and its own risk factor. Risk factors include toxins, viruses, hormones like estrogen, and ovulation. Precancer is usually the carcinoma in situ or simply dysplastic tissue. And cancer is either adenocarcinoma or sarcoma. And the goal of each stage changes as well. For etiology, what you want to be able to do is identify risk factors. And prevent exposure. During the precancer phase, they've already been exposed, but now if you have the opportunity, you want to screen. Because if you find disease at the precancer phase, a local resection is curative. Nothing radical needs to be done. If you wait until the cancer phase to find something, now you're actually just simply diagnosing it. And the only thing you can do is debulk. You do surgery to remove the cancer, and generally you're going to need to do chemotherapy. Obviously, this is going to be stage dependent. So you're going to see this setup in each of the cancer lectures, that some sort of etiology leads to a precancer and leads to a cancer. The other thing you're going to see time and time again in these lectures is age stratification based on reproductive age. So over the course of a woman's life, around 11 years old, she'll undergo menarche. And around age 51, she'll undergo menopause. And so the premenarchal girl will have significantly different risk than a postmenopausal female, which is different than the reproductive aged woman. Because in the premenarchal phase, there's no estrogen. There's no ovulation. She's not sexually active, so there's no exposure to STDs and viruses. The only thing that can cause cancer in a premenarchal girl are toxins. By contrast, once she enters reproductive age, she starts having sex, so she becomes exposed to viruses. She begins to ovulate. And those ovaries begin to produce estrogen. In the postmenopausal period, no more ovulation occurs, but she's had a lifetime of exposure. And so not surprisingly, cancer incidence increases the older you get in general, because most GYN tumors require some long-term exposure to viruses, ovulation, or estrogen in order to induce them. And the longer someone is around, the more time they've had to be exposed, the more time they have had for that one cancer cell to go dysplastic and turn into cancer. And you're going to see certain cancers are more common in different age groups. We're going to use this setup even beyond the cancer setup. We're going to use it in almost every lecture you see in GYN. Now let's talk about the different structures in GYN that can cause a tumor. You're going to see this drawing often in these lectures. This represents the uterus. Tubes, ovaries. Tubes, ovaries. This represents the vagina, and this the vulva. The cervix is here where the uterus meets the vagina, where ectocervical and endocervical lesions of cervical cancer can be seen. The vagina can develop most often squamous cell carcinoma. The vulva can have vulvar cancer, which is most often squamous cell carcinoma, or a special variant, which will be red on appearance, Paget's disease. The endometrium can become dysplastic, and you get endometrial adenocarcinoma. And finally, the ovaries can become ovarian cancer. And the type of ovarian cancer is dependent on which cells within the ovary are affected. You'll see more details on that in ovarian cancer. And I want to make explicit one of the things I just did. The cell types found in the different cancers are represented in color code. Ovarian cancer has different cell types than endometrial cancer. It's different than cervical cancer. But cervical cancer, whether it's ectopic or endocervical, squamous cell carcinoma of the vagina or vulva, all are generally squamous cell carcinoma. So note that they're color-coded, and that Paget's is the exception to this rule, is one special one. So if you have in your head etiology, precancer, cancer, age bracket, and structure, you're going to be able to follow along much better with the coming lectures. And so let me give you an overview based on these teachings of what you're going to have to know in the coming lectures. And if you have this chart with you at every lecture, you'll see how it fits into the grand scheme. Cervical cancer, vaginal, and vulvar cancer are all caused by infection with HPV. The precancer is carcinoma in situ and dysplasia. The cancer they form is squamous cell carcinoma, the exception being that vulvar cancer can be both Paget's or melanoma, and that there is no screen for vaginal or vulvar cancers, but there's a pap smear for cervical. The patient is going to present with cervical cancer as a postcoital bleed. Vaginal cancers are generally going to be black and itchy. So are melanoma and squamous cell carcinoma of the vulva. But don't forget about Paget's disease, which is red and itchy. Endometrial cancer is caused by exposure to estrogen. It goes through dysplasia and several types of atypical cells, and then becomes adenocarcinoma. There is no screen. The patient normally presents as a postmenopausal bleeder. Ovarian cancer is etiology specific because there's so many subtypes. I'm going to talk about the poor prognosis epithelial ovarian cancer, the one that actually matters. It's caused by ovulation. You almost never detect precancer, but it's something called low malignant potential cells. The type of cancer that it becomes is from an epithelial cell, but there are various kinds. Teratomas, choriocarcinoma, endometrial sinus tumors. serous cystadenocarcinomas. It's variable based on the type of cell that it is. There is certainly no screen. And the patient will present with renal failure, a small bowel obstruction, ascites, or will simply be an asymptomatic mass. Last on this overview list is choriocarcinoma. Chorio comes from any sort of gestational trophoblastic disease, that is moles, incomplete moles, and even normal pregnancies. It is itself a precancer, the gestational trophoblastic disease, and the cancer is choriocarcinoma. There's no screen, but in patients who have moles, you're going to see that we follow the beta-HCG because elevations in the beta-HCG without pregnancy are indicative of chorio, and the patient will present with similar symptoms. That is, size-date discrepancies, and other symptoms of elevated beta-HCG, hyperthyroid, or hyperemesis gravidarum. So as you are going to go through each of these lectures, what you're going to look at is etiology, precancer, and cancer. You're going to risk stratify each cancer based on an age group. You need to know how to screen for these cancers, how to diagnose them, and how to treat them. And I'll tell you a shortcut. We have only one screening tool for all of the GYN cancers in general. There are some exceptions based on certain populations. And that is the Pap smear. The Pap smear is the only screening for any GYN tumor. That is introduction to GYN cancers. We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.